This is a patient from Morocco after failed REFEK surgery in Boston, referred for exchange keratoplasty. I begin by first removing the epithelium to better visualize the anterior chamber anatomy, pseudophakic in this case. Perform the self-sealing scleral incision, which is astigmatically neutral. I prefer metal instruments over diamond to create better resistance entry for the anterior chamber maintainer. I now use my modified Sinski instrument to delineate and score the previous DSEK graft along the entire circumference, and I determine that it is easily separated. In some areas I create or repeat to break any adhesions, and now fold it on itself to do a keratorhexis, if you may, pulling it along its border inferiorly, very much like a capsulorhexis, and it follows its previous circumference and separates. In some area you may require a little more force, as you can see here, and you can go back in those areas and pull accordingly to a complete separation. Make sure that the entire graft is fully separated and free-floating. Entry into the anterior chamber. Using the same instrument, I bring out this previous DSEK graft, examine it on the patient's cornea. Her previous surgeon had obviously done an excellent job. The graft is 8 millimeters in size and complete. This is now removed and sent for pathology. I now focus on the donor cornea and fold it to make this mark in particular as a teaching modality to determine the stromal surface. I'm making a number 7 on the stromal side, and now fold this graft in a 60-40 configuration, and with the modified Gulani forceps, I insert it into the anterior chamber and gently release to see it unfold. Tap it as it unfolds in the anterior chamber. Put in an air bubble at this point. Try to move this graft to the center and within the previous DSEK zone. I remove the previous surgeon's sutures from his temporal incision. Remark my astigmatism axis, once again the focus being as emmetropic or refractively neutral surgery as possible. My draining incisions I'm going to make along the astigmatic axis, and with my special marker that I've designed, I rotate it in the area so I can gently insert my diamond in that slot on the predetermined axis to perform my release incision on the cornea, which also corrects the astigmatism pre-existing in this patient. And that's a diamond blade through the slot. You can see in high magnification a nicely done diamond incision like a mini AK right there. Use of XL to squeegee any interface fluid between the donor and recipient cornea, and that fluid can egress through these incisions. I now perform an inferior iridectomy using microforceps and scissors and go back to splay the area to determine a full penetrated iridectomy. I now enter with BSS to decrease the size of the air bubble in the anterior chamber, at the same time determine its full mobility and graft adherence. Confirming graft adherence with the cerebral sign, I am using the resure sealant at the main incision to also secure the incision with the conjunctival flap for added comfort. Also trying to lay it as flat as possible and squeegee the excess fluid and edema, while at the same time decrease the amount of excess sealant in the area, as seen here. Again, trying to squeegee, make it as flat as possible and yet well aligned to cover the incision safely. Remove the excessive sealant to create less irritation next day or foreign body sensation. And now use the sealant on the previous incision, including paracentesis that I created. And we have now performed an endothelial keratoplasty, keeping all the principles of refractive surgery foremost in our mind, from keeping the surgery astigmatic neutral to actually improving astigmatism during our drainage incisions and closing all incisions with sealant instead of sutures to increase the patient's comfort, appearance, and vision the best we can. Antibiotic and steroid drops. Case complete. Immediate post-op. Next day post-op with a clear cornea, reshore sealant with fluorescein and without fluorescein, confirming a good closure, well-adhered endothelial keratoplasty, and a very happy patient ready to fly back home.